Coming to the etiology, this is the age-old classification that we have been seeing from MBBS time, where we classify it into pre-renal, intrarenal and post-renal, right? Now, intrarenal, if this is the kidney and this is the renal vein, renal artery, and this is the ureter. So, pre-renal, it has to do anything with vasculature or whatever blood is there inside the vessels, something to do with it. Intrarenal is when it comes inside the kidney. The cause of acute kidney injury comes inside the kidney. And post-renal is when it happens outside, after the urine leaks outside the kidney, or it is in the collecting duct system, okay, which might be collecting duct pelvis, or it's in the urinary tract, which involves the pelvis or the ureter or the bladder, okay. Now, intrarenal further can be classified into vascular, glomerular, tubular, interstitial. So, if you take the cross-section of a glomerulus, cross-section of a renal biopsy, you see glomerulus. Glomerulus, the afferent arteriole comes and becomes glomerular capillaries, goes as efferent arterioles. Apart from this, that there is interstitium, and there is going to be tubules, and there are going to be these blood vessels. So, which are the four compartments in this? So, one you see is vascular. The second you see is interstitial. Next you see is glomerular. After that, what you see is tubular, right? So, these four components, if it is, once AK comes, you have to distribute them into these. You can see whether it's pre-renal or post-renal. If not for this, if it is intrarenal, you should see which compartment of this it fits into. Now, this is the cause of AK. This combines everything. So, first going to pre-renal cause. Okay, so like I said, it can be hypovolemia. See, anything that leads to less blood supply into the kidney. So, it can be hypovolemia, or it can be cardiac failure, or it can be hepatorenal syndrome. Okay, in hepatorenal syndrome, what happens? There's a detailed chapter coming about this. But in hepatorenal syndrome, what happens is there is splanchnic vasodilatation, right? So, blood pooling occurs there and less amount of blood reaches the kidney. So, anything that leads to less blood supply to the kidney, that is pre-renal. Now, coming to the renal artery. Okay, this is the vascular component where there is renal artery occlusion or dissection, large or medium vessel vasculitis. So, in vasculitis, like if you go to the vasculitis chapter, we would have discussed this in detail, where the vessels are involved. So, in that condition, acute kidney injury can happen, okay. Similarly, if it is renal vein, just because I started artery, I'll finish off the vein also. If it's renal vein thrombosis, bilateral renal vein thrombosis can cause acute kidney injury. Unilateral generally does not cause. You have to remember this, it's generally bilateral, okay. Now, coming within the kidney. So, here if you see, they have taken a small section of the nephron and they have enlarged it. So, here inside this, the small vessel disease like TMA or renal atheroembolism. Then you go to the glomerulus, which is all the causes of glomerulonephritis that which might be small vessel vasculitis, anti-GBM, lupus, IRGN, that is post-infectious glomerulonephritis, or infective endocarditis, membranoproliferative glomerulonephritis, cryoglobulinemia, and IgA, okay. Next, coming to the tubule, ATN. ATN, acute tubular necrosis, can happen because of endogenous causes or exogenous causes. Endogenous causes is by rhabdomyolysis or intravascular hemolysis. Exogenous causes, let me just write this down. It can happen because of endogenous causes or exogenous causes. Exogenous causes are going to be because of any nephrotoxins or radiocontrast agents, okay. Next is interstitium. So, we finished the vessels, we finished the glomerulus, we finished the interstitium, we finished the tubule. Coming to the interstitium. Interstitium, acute interstitial nephritis. We have covered this in detail in the chapter of acute interstitial nephritis. Any drugs, infection or systemic disease, okay. Now, intratubular obstruction can happen again because of cast, like in multiple myeloma or some drug induced. So, again drugs or crystalluria. Now, post-renal obstruction comes in this part where there is coming from down, there can be bladder outlet obstruction. It can happen because of bladder CA. There might be some calculus in the ureter or somewhere here, or the kidney, the renal papilla can slough off, blocking the ureter, causing in renal papillary necrosis, or there can be retroperitoneal fibrosis blocking the ureter. So all these causes becomes the post-obstructive reason for acute kidney injury. Okay. So these are the causes of acute kidney injury. Now in the hospital setting, what are the causes? So here you can see the most common causes acute tubular necrosis, followed by pre-renal. This is the second most common cause. After this you see acute on chronic kidney disease and obstruction. The acute interstitial nephritis or vascular causes like renal artery thrombosis, atheroembolism are rare. Even RPGN is a rare entity. So remember, in hospital setting, the most common cause of AKI that we notice is acute tubular necrosis, followed by pre-renal, which can be because of hypovolemia or cardiorenal syndrome or hepatorenal syndrome, followed by acute on chronic kidney disease. Now, what happens in pre-renal acute kidney injury? What happens in pre-renal acute kidney injuries? There is impaired renal perfusion. This we already mentioned. Enough blood is not coming into the kidney. Okay. So why does enough blood not come into the kidney? One is there can be extracellular fluid volume depletion. This can happen because of GI causes like diarrhea, or it can happen because of renal causes like polyuria or using some diuretics. Okay. Or it can happen because of excessive loss from the skin, like in burns. Okay. Or it can happen because of third phase sequestration of fluid. Okay. So this can happen in conditions like pancreatitis, or it can happen in conditions like dengue shock syndrome, or it can happen in rhabdomyolysis where large amount of fluid gets collected in one compartment. Okay. So one is because of volume depletion. The next cause is because of volume excess, but that excess is somewhere else not reaching the kidney, like in congestive cardiac failure, where all the reverse back pressure, all the hepatic vein dilatation and IVC dilatation, renal vein dilatation is going to affect the kidney. Okay. Or it can be because of hepatorenal syndrome. Okay. In hepatorenal syndrome, again, like I discussed, there is going to be splanchnic vasodilatation. Okay. So this can cause reduced blood reaching the kidney. Now, what is the pathophysiology? Pathophysiology, what happens? There is reduced blood reaching the kidney. So kidney is going to try to reabsorb everything. So if you check urinary sodium, it's going to be less than 20 millimole per liter because there's going to be reabsorption of sodium and water. And urine is going to be highly osmolar urine, that is very concentrated urine, because body is trying to excrete only little urine, minimal urine that is required to excrete the solutes, and sodium is going to be very less. And what is the difference that happens in this condition is, because if this is the glomerulus, this is the afferent artery, assume this is the capillaries, and this is the efferent artery, right? Now what happens if more blood has to reach the glomerulus? This afferent arteriole has to vasodilate, right? So afferent arteriole undergoes vasodilatation, and if all the blood comes, it just goes away, there's no point. So what should happen to the efferent arteriole? It should vasoconstrict. So imagine two pipes like this through which the blood is flowing, right? Now you want more blood flow stay. Imagine a cup here, okay? Now you want more blood to stay in this area. So what are you going to do? You're going to increase the size of this pipe and reduce the size of this pipe. So the blood is going to stay here for a long time so that filtration occurs. So this is the concept that is happening in the body. So efferent arteriolar vasoconstriction happens, okay? Pathophysiology and etiology of post-renal AKI. So it can happen in patients who have some pre-existing risk factors with increased risk of forming stones, or patients who have some obstruction anywhere. So like we discussed, the causes of obstructive AKI. Okay. Now pathophysiology is there is going to be increased intratubular pressure, right? So what is going to happen if this is the glomerulus and this is the tubule, loop of Henle, distal tubule and collecting duct. And collecting duct, right? Now what is going to happen? The urine flow is going to be blocked. There's going to be increased pressure in the tubule. So always here in the glomerulus, there should be higher pressure than the tubule. Then only filtration will occur. So this increased intratubular pressure is going to oppose the glomerular filtration pressure. So filtration is not going to happen and reduce GFR. So here the pressure should be always higher than this tubule. Okay, so what happens is, because this tubular pressure is high, the glomerular filtration does not happen, and because of this, the GFR reduces. Pathophysiology of acute tubular necrosis. It can happen because of ischemic injury or nephrotoxic injury, and when there is fever, it exacerbates ATN because metabolism increases. And if metabolism increases, all the channels are being used. If all the channels are being used, then more energy is required for the tubules, and this itself can lead to its death. So if it's uncomplicated ATN, generally recovery happens between 2 to 3 weeks. So this is what happens generally in ICUs. In wards, when we have patients with acute tubular necrosis and they're on dialysis, and if the patient attenders ask us that how long it will take for recovery, this is the general time span we give, 2 to 3 weeks. In uncomplicated cases. But imagine if there's a complicated case that the patient's stay in ICU is getting continued. Then in this situation, what is going to happen is repeated episodes of ATN or AK can happen, and this can worsen the acute tubular necrosis, and recovery might be much delayed.